Okay. Okay. So, good evening, all of you. I guess I'm connected. There was some problem with connection, so it took some time, but I guess we are connected now. So, let's quickly go to the questions asked on this Sunday in INICET exam. And I'm happy that most of the questions of GIT were from the topic I discussed with you. Even I showed some images of some approach and all were asked. So, this is question number 1. And I always emphasize the important syndrome asked. Peutz-Jeghers is one of them. So, this I discussed in regular batch, in TND as well as in recall and everywhere. So, the question was, what is wrong? We all know Peutz-Jeghers is autosomal dominant, chromosome 19 and gene STK11 or LKB1. And it's characterized by pigmentation on the lips and mucocutaneous pigmentation and polyps. So, this is autosomal dominant, not recessive. A is wrong. Arborizing is right. This is called Christmas tree appearance. Extra intestinal recession is right, and hematomatous polyp is of course right. So, A is wrong. Next question is, so this is a arborizing pattern and pigmentation on the lip. Which of the following gets first priority in triage? 45-year-old unconscious patient with noisy breathing. This of course will go in red zone because you know A, B, C, airway breathing circulation. Airway gets the first priority. So this gets the first priority. Of course, here also breathing difficulty. He will also go in red, but he is at least conscious. As far as C and D is concerned, they are not in the picture. Only A and B, they will get the first priority. And out of these two, A is unconscious. So answer should be A. Which of the following is correct about Hirschsprung disease? Hirschsprung is absence of ganglion which fail to migrate. In fetus, the ganglion, Auerbach and Mantriflexes, they reach up to lower part of rectum and canal by the end of 12th week of intrauterine life. If they stop somewhere, this distal part remains aganglionic. So that's right. Causes intestinal obstruction? Yes, that's correct. The main presentation of Hirschsprung is delayed passage of meconium or unable to pass meconium. Proximal segment is not constricted. Proximal segment is dilated due to back pressure. The distal segment is constricted, which is aganglionic, and non-coordinate peristalsis is right. So 1, 2, 4 right. 3 is wrong. A 60-year-old patient presents with bone pain and easy fatigue, serum calcium elevated, phosphate low, and SAP is elevated. X-ray shows diffuse osteoporosis. Which of the following? Well, this is classical hyperparathyroid, and for that the best screen is PET scan, system AB. So system AB is of course the scan for parathyroid. So answer is B. Treatment of inflammatory based cancer, and there was a photo. Sorry, I forgot to put the photo here. The photo showing the inflamed surface of the skin, more than 1/3 of surface area. So that was inflammatory based cancer. Of course, you have to give neoadjuvant chemo and modified radical mastectomy. I think adjuvant radio chemo was not given in the option, but of course, in treatment, you have to give adjuvant radio chemo also. So neoadjuvant, adjuvant both were given. Out of these 4, this is the best answer. Now, this question, there's some controversy. Some students saying this was a cystic swelling, some saying the picture was like this. So if the swelling was like this, of course this is choledochal cyst. Lipase and amylase normally we don't order in this. So it was really raises some questions, and abdominal pain is fine. Choledochal cyst presents with recurrent jaundice, not pancreatitis. It can cause pancreatitis type 3, choledochocele, and really a lower position of choledochal cyst. So this, of course, if picture is like this, it's a choledochal cyst, no doubt, but the image does not match with the symptoms. So in this case, if it was like this, like Centoni here and Wilson here, 2 duct, then the answer would be pancreas divisum. Annular pancreas is unlikely to be an option. Annular pancreas normally does not present with pancreatitis, it presents with duodenal obstruction. So if the picture was like this, and I personally feel that picture must be like this, because choledochal cyst is a very, very favorite topic for INICET. Every year they ask one question from choledochal cyst. So it's up to you. I mean, you gave the exam, you wrote the paper, you have the idea. If it was like this, it's choledochal cyst. If it was like this, it's pancreas divisum, where the ventral bud forming this part, duct of Wirsum, dorsal bud forming this part, body and tail duct of Centoni, and both ducts do not fuse, they remain separate. This is pancreas divisum. So first, like here, and the problem is in this duct, minor papilla, dorsal duct. This needs papillotomy. Papillotomy of the dorsal duct, minor papilla. Now, so this is pancreas divisum, 2 pancreatic duct, and this is choledochal cyst, which I am sure you can very easily identify. Now, here also there is some problem. Some students saying it was Meikles like this, which is later hernia, and some was saying appendix like this, which was a Maynard hernia. So, if it's Maynard, not amygdals, it is Amyands, Maynard. So, appendix means Maynard, you have to again recollect whether it was appendix. Some students are saying that even the tinea coli can be seen on the cecum. So it was Maynard. Some say no, it was Meikles. So if Meikles was the content of hernia, it was Litters. If appendix was the content of hernia, it was Maynard. But what I gather from after talking to many students, probably it was Maynard, it was appendix. Identify the wrong statement about late dumping syndrome. Late dumping syndrome is due to hypoglycemia. When the patient eats, food rapidly enters small intestine, sugar gets absorbed, so GLP-1 stimulated and insulin stimulated, causing reactionary hypoglycemia. So about between 1 and 3 hours, patient has hypoglycemia. So this is right. Physical activity will further aggravate hypoglycemia. This is right. Clinical features include tremor. These are features of hypoglycemia. This is right. Symptoms are relieved by lying down. This is wrong. Early dumping syndrome is relieved by lying down. This is late dumping syndrome. This is relieved by sugar or food. So this is the wrong statement. And this is repeat question. And fortunately, I used this question also in one of the grand tests this year only. Same question. Figaro is for chronic pancreatitis, where T is toxic and metabolite, I is idiopathic, G is genetic, A is autoimmune, R is recurrent, and O is obstructive, recurrent acute. So this is Figaro, and this I'm sure is a very basic question. All of you must be knowing this. Now again, some students say that the picture was like this is sleeve gastrectomy in Roux-en-Y, which of course is duodenal switch, and some are saying distal gastrectomy in Roux-en-Y, then this is biliopancreatic diversion. Although this is kind of obsolete, we don't do this surgery. So my gut feeling says it must be like this, but I do not know. If the picture was a sleeve, I'll show you the image. If a sleeve gastrectomy in Roux-en-Y, then this is duodenal switch. Distal gastrectomy in Roux-en-Y, this is BPD, biliopancreatic diversion. And no gastrectomy in Roux-en-Y, this is Roux-en-Y gastric bypass. Sleeve gastrectomy without Roux-en-Y, SARDS. SARDS was asked in May INICET this year. So you can now revise, you can recollect whether it was sleeve gastrectomy in Roux-en-Y or whether it was distal gastrectomy in Roux-en-Y. Chief guest statement given by did not switch. District guest statement given by BPD. Steps of laparoscopic cholecystectomy. This also is simple. I mean, even if you do not have read this common sense, you can answer this question. First will be create a pneumoperitoneum, then dissect the calloid triangle, then ligate the, first you ligate the artery, then the duct. The sequence is wrong. First artery, then duct, and then you separate the gallbladder from the liver bed and take the gallbladder out. So A, B, C, D, this is the sequence. The angle between two working ports, angle between two instruments is called manipulation angle. Angle between the table and the instrument is called elevation angle, and between the scope and instrument is called azimuth angle. Azimuth angle was asked very recently in one of the exams. So azimuth angle is between the scope and the instrument around 30 degree. Manipulation 60 degree between two instruments. Two instrument is manipulation C. A patient with recurrent history of gastric ulcer presents with severe abdominal pain. On evaluation, small mass is found in the anterior wall of the. Gastric ulcer and duodenal lump is gastrinoma. We all know gastrinoma comes from first part duodenum most commonly, second part duodenum and head of pancreas, 90% from duodenum. This is gastrinoma. So the answer is gastrin. You order the gastrin level. This is simple Zollinger ulcer syndrome, a duodenal ulcer, a gastric ulcer and duodenal tumor. This is gastrinoma. A patient presents with abdominal pain. On evaluation, patient has raised mucin. High mucin and CEA level and normal amylase, of course, is the mucinous cystic neoplasm of the pancreas. Because if it is serous, the mucin will not be there, and normal amylase suggests it's not pseudocyst. Pseudocyst will have no CEA and high amylase. So this is mucin and mucinous tumor of cystic tumor of pancreas. Sequence of step of hernia surgery, and again it's simple common sense. First you give incision, then you, probably there was a sac dissection or something. So that's second, third is mesh placement, reinforced, fourth is wound closure. So of course this is the sequence. Now here also there's some confusion. This of course is extradural hematoma, and some are saying craniectomy was given as the option, some are saying craniotomy was given. If craniotomy was the option, then this is the best answer. The standard treatment for extradural is craniotomy, subdural also is craniotomy. If craniectomy is the option, let's remove craniotomy. If craniectomy, that like you remove some bone part, no, you don't remove bone. Unless there's a shattered, some fragments are there or it's infected, otherwise craniectomy is not done, then burr hole is the best answer. Burr hole actually is too small to evacuate the complete hematoma. Burr hole is normally done when OT is not available, you want to decompress this cranium, pressure is going up, then you can do it. Burr hole is a minor procedure. So standard treatment is craniotomy. This is the ideal treatment for extradural or subdural. But yes, burr hole can be done as an initial step if OT is not available, as I said, or you want to decompress. So if craniectomy is the option, then answer is burr hole. And if craniotomy is the option, that's the answer. Maximum tissue reaction is seen in the natural chromic catgut. Some are saying chromic is not there, doesn't matter, still the answer is catgut. Catgut being natural, coming from some yugos of sheep, has the maximum tissue reaction. And of course, least is seen in steel. That is the old question. Stainless steel wire has the least tissue reaction. Non-absorbable normally has less reaction, monofilament, than polyfilament absorbable. So catgut has highest tissue reaction. It's digested by enzymatic action, and these three are digested by hydrolysis. So enzymatic action, absorbable, natural, all makes it more prone for tissue reaction. A patient with hypothyroidism was recently completed 13-hour long fight. So basically they're asking what is the risk for deep vein thrombosis, and emulation of course is risk, smoking is risk, OCP is a risk. According to book, even hypothyroid is a risk. If you ask me, I'll say all four, but out of there's the option of all four, so I'll go for this. Hypothyroid is a rare reason of DVT. It's a reason, not, I mean, rare reason, it's a reason. And otherwise, 2, 3, 4 are definitely a prominent reason. Hypothyroid is not a prominent reason, but theoretically that also is a reason for DVT. Hypothyroid also is included. 20-year-old male presents with pain in retinal fossa for last 24 hours, diagnosed as acute appendicitis. Actually, here multiple answers are correct. IOC is children, yes. Classical cytotenderness is McBurney, but this is not diagnostic. Huh? Remember, it's not diagnostic, but classical site is, so this is true, but not diagnostic. It's not saying diagnostic, it's saying classical. Osner-Sherin for lump, yes, this is true. Prompt appendicectomy, no. There's the option of interval appendicectomy. So A, B, C are right, D is wrong. Sometimes we manage conservatively and go for appendicectomy after 6 weeks. So D is the wrong statement. But multiple answers correct, so I'll go for ABC. And again, I'm saying, because it's saying classical site, it's not saying diagnostic, so this is true. Arrange the steps of hernioplasty. Oh, sorry, already I've told you. Skin incision, identify sac and reduce the content, or you can say close the opening, place the mesh and close the wound. Match the following investigation. Well, manometry, you know, is ecclesia cardia, pH monitoring for GRD, system B for parathyroid. Already we had a question like this, and endoscopic ultrasound for CA esophagus to know the depth and node stage. Now, here also you have, I mean, unless the picture is very clear, it's very difficult to identify. If there are blisters, if it's pink, moist, glistening, painful blisters, then this is superficial partial thickness. But this image is more suggestive of deep partial thickness, which the pain is relatively less and it's more thick without blisters. So it of course is partial thickness. Whether superficial or deep, that the image will describe. Like this is a glistening red moist. This is a partial thickness, superficial. This is deep and this is full thickness, where the color has changed. It doesn't blanch on pressure. Pain is less because nerves are destroyed. So some other features are there. So depending on the image, but I'll go for deep partial thickness for this particular image, if this was given. Yeah, this was the question, sorry. So I discussed this earlier. This is the question where you have, inflammatory-based cancer, neoadjuvant chemotherapy followed by MRI. And then of course, adjuvant chemo is also good, chemoradiation. A patient has undergone laparoscopic prostatectomy. A drain was inserted because of difficult gallbladder dissection. After 7 days, 300 ml output is there. Patient afebrile. CT does not show any correction. MRCP shows cystic stump leak is Strasbourg type A injury, which is managed by ERCP with stenting. Usually with stenting. You do ERCP and papillotomy and sphincterotomy. So this is a ERCP from the cystic stump leaf. Just put a stent and do papillotomy. That's the answer. We don't re-explore. So best answer is A. A patient has undergone laparoscopic prostatectomy. And now this question, I'm not very happy with the wording. I'm not sure this is a question because drain is already there. If drain is there, then what's the point of putting a percutaneous drainage? Already drained, the question says, but this is the best answer here. When you have collection on day 1 or 2 and patient afebrile, you don't do anything. So post-op observation, some collection is there, put a drain and wait for a day or 2 and get a MRCP, ERCP done. There's no, laparotomy is not done. I'll not ligate unless I know where it's an observation. I mean, drain is already there. So out of these 4, best answer is observation. Because drain is already there. So what's the point of putting percutaneous drainage now? If this is there, answer is observation. If drain is not there, then answer is percutaneous drainage. So I'm not convinced about this line because if drain is there, then why the collection is there? The collection should be out. So best answer here is A, if drain is there. Drain is not there, go for percutaneous drainage. Pigtail capture, put it there. Identify the wrong statement. Ileostomy loop is generally kept pouting. Yeah, that's called Brooks ileostomy. So see, this is the skin surface. Ileostomy is kept little elevated. This is the opening. You invert it. Why? Because the content of ileostomy contain lots of enzymes. They excoriate the skin. You don't want the content coming out of the ileostomy to touch the skin. So it's kept pouting. Brooks ileostomy, that's correct. Maximum malabsorption. Electrolyte malabsorption is more when the leak is more proximal. Like duodenum has maximum leak, then jejunum, then ileum, then colon. So colostomy, the fluid loss and electrolyte loss is least actually. Stoma is usually flat. Okay, flat or slightly elevated, that's correct. And loop ileostomy generally is temporary, that's correct. So B is wrong. And finally, this question, I'm not sure it was there, but someone told me it was there. There's a lump, there's a mass in apex of the lung with tingling in the right hand, impaired vision. This is Horner syndrome. C8T1 gets compressed, causing tingling, and sympathetic ganglion gets involved. That is ptosis, meiosis, anhidrosis, and ophthalmos. That's causing vision impairment. So best is CT and CT guided biopsy. So these were the questions I could gather from INICET this. And if you ask me, I'll say the questions were straightforward. The questions were much simpler or straightforward as compared to previous INICET or PG exam. So that's it for today. All the best to all of you. Thank you.